My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan, and our Learn and Share conference call this evening is on epilepsy and the immune system. And we're very pleased to have with us Dr. Mitchel Williams, who is a pediatric neurologist with Children's Hospital of Michigan. So Dr. Williams, welcome.
Thank you. Thank you for having me.
Yeah. So can you start by just sharing a little bit about your clinical and research interests and also your experience with this topic?
My clinical interests are kind of specific to certain disorders where the nervous system and the immune system kind of overlap. It's a relatively new area within neurology, and it's so new that there's not really any training programs in North America for this. So this is kind of a very new and developing area. So my area of interest has been in several different neuroimmunological disorders, including autoimmune epilepsies, as well as other immune-mediated conditions that affect the nervous system, those being multiple sclerosis and other autoimmune neuropsychiatric disorders.
Okay, great. So go ahead. Were you going to say something else?
Well, I was just going to say some areas of research that we've been looking into is looking at different biomarkers for these diseases because, again, they're relatively new described, so diagnosing it can be a diagnostic challenge sometimes.
Right.
So we've been trying to develop new tools to help us, one, diagnose them more readily, and also be able to use something to know how our treatments are affecting the disorder.
Great, great. So you're doing some pioneering at work, it sounds like. It's a very new field relative to the rest of medicine and pediatrics and neurology, to be honest. So it's exciting, but there's still so much that we're learning about how the immune system has its direct or indirect effects on the brain. Right. Okay, so I think everyone has a basic understanding of the role of the immune system and what it's for, but can you give an overview of how the immune system works, both on a cellular level and on a larger scale?
Yeah, definitely. So the immune system basically has three tasks that it tries to accomplish. One of the tasks that most people are familiar with is to neutralize and destroy pathogens like bacteria, viruses, parasites, fungi, and other invaders that get into the body to destroy them and remove them. Another task that it does is it tries to recognize and neutralize foreign and harmful substances from the outside environment that get inside the body. And the third main thing is actually one that many people don't know about the immune system, is it actually fights against the body's own cells that have changed due to an illness. An example would be cancer cells. So it's important, for the body to be able to know the differences and recognize, foreign from self, and also cells that have changed in the body and now that are behaving, badly. So they can recognize that. So for this type of protection to be effective that the immune system does, it has to differentiate between self and non-self cells, organisms, and other substances. So usually these non-self substances, we refer to them usually as what we call antigens. Now these antigens can be, most of the time when it's like a foreign organism, are usually proteins that are on the surface of these organisms, and these antigens that are the proteins are recognized by special receptors on these defense cells, and then once these receptors bind to these antigens, then a whole cascade of processes start with the immune system to recognize them. So the immune system can create new memory, so they can remember a previous infection, so that the immune response the next time is much quicker. These are stored in memory cells, so that they can quickly reactivate in the future. That's how we build up an immunity to certain infections that we've been exposed to in the past. Now, the immune system is kind of divided into two broad parts of the immune system. One is called the innate immune system. This is kind of our older and more generalized defense against these pathogens. It's more nonspecific, and it uses these kind of type of killer cells that kind of scavenge and will basically directly fight and destroy bacterial infections and such infections. The other arm of the immune system is the adaptive immune system. This is the one that has like the memory cells that are able to produce antibodies. Now these antibodies are little tags that attach to the antigen and mark it to be recognized and destroyed by the immune system. So this part of the immune system is constantly adapting and learning and changes over time. As we get older, that part of our immune system becomes more learned and specific to infections that they've seen in the past.
Right. And how does this actually manifest when our immune system is working? How does this manifest in terms of symptoms we might experience?
Right. So, I mean, when the immune system is working well and it's just monitoring the environment and not really actively attacking anything, right, we hardly ever notice that our immune system is doing anything. But when it becomes activated because of either, an invading bacteria or virus or something else, usually the first response that most people are familiar with is, either a localized reaction, swelling, redness, inflammation. Other things we see are the systemic or more generalized reaction, which would be like fever. Other things that we get body aches or chills. These are reactions by the body and immune system to make the environment less hospitable to these invading organisms, and also start to get the immune system ramped up and more activated.
Okay, great. So there are a few key ways in which the immune system can malfunction. You can have immune deficiency, allergies and asthma is related to immune malfunction, and then also you mentioned this earlier, autoimmune disease. Can you talk about the defining characteristics of each of these types of immune disorders?
Right. Now, I mean, there's definitely a lot of overlap that can occur amongst these, but
Sure.
Starting off with immunodeficiency or these type of disorders where the immune system is impaired, these basically are where your immune system is not adequately developed, or either because of an acquired disorder that happens after you're born, or could be something congenital, which may be related to underlying genetic condition. So these immunodeficiency disorders can make fighting infections and other diseases harder for you to do, so it can make it easier for you to catch certain infections or even develop certain types of cancer. So again, we tend to categorize these either as congenital or acquired, and these congenital ones also are referred to as primary disorders, ones that you're born with. And then the acquired are also referred to as secondary. So these are disorders that you can develop later on in life. Acquired disorders tend to be more common than congenital, actually. Now, allergies, this is part of the immune system that reacts to specific substances, which we call as allergens. So now these allergens are things that will trigger an allergic response. Now, it's common if people have allergies, it's common to have more than one allergic disease. And usually kind of symptoms or manifestations of that are, very specific in different ways. They can include nasal or eye symptoms, allergic asthma, eczema, hives, or even more of what we call a systemic response, which we refer to as anaphylaxis, which can be life-threatening, where you can have swelling of the airway, lips, skin, and other diffuse rashes with that. Now, the allergic reactions that we see are allergies. This is part of the immune system where the person develops very specific antibodies. Again, those little markers that tag things. Their specific antibodies are called IgE. And they're very specific for a particular allergen. So they're not going to cross-react or react to the same thing. It's only going to be very specific. Now, these IgE antibodies, bind tightly. Once they bind to the allergen, they recruit these allergic cells, which are called mast cells. Once they bind to that, then they release their contents, which is usually a substance like histamine or a histamine itself, and that's what causes the allergic reaction. Depending on where in the body the reaction happens, it depends on the kind of response that you have. So to kind of differentiate that, now our autoimmune disorders are a bit different. This is where your immune system is not able to distinguish between healthy tissue and the foreign antigens. Now, as a result, your body starts to set off a reaction that tends to destroy normal tissue or causes the organ that is attacking to act dysfunctionally. Now, the exact cause for a lot of these autoimmune disorders is not known. One theory that is fairly prevalent is that some organisms or infections or even drugs can trigger the immune system and cause it to confuse it to cross-react with another protein or antigen in your body that normally it should recognize as being self. So then it starts attacking it. This process can also happen with certain types of tumors that can happen. Now, this tends to happen more often in people who may have certain genes that make them more prone to autoimmune disorders. That's a big area of research, is to identify these genes or a collection of genes that make the risk of developing autoimmune disease more prevalent, especially in families. So usually an autoimmune disorder can usually cause like destruction of the tissue, abnormal growth of an organ or tissue, or it can change the function of the tissue or organ. The autoimmune disorder can affect either one or many different organs or different types of tissues. It just depends where that antigen in the body is expressed.
Okay. So from what I've read, it sounds like most cases of epilepsy that have an immunological cause involve an autoimmune response as opposed to immune deficiency or allergy. Is that generally correct?
Yeah, that's generally correct.
Okay.
Correct. Usually, what we see is that the immune response is more of an autoimmune, so it's recognizing part of the nervous system rather than it being actually an allergic reaction or a type of immune deficiency.
Okay. So can you talk about the suspected mechanisms by which an autoimmune response can lead to epilepsy?
Right. So what we tend to see is autoimmune disorders, they tend to cluster even within the same individual. So a lot of times people who have one autoimmune disease can have more than one. And that, again, is likely due to their underlying genetic risk factors and also personal risk factors. Certain things in the environment can increase the likelihood of developing autoimmune disease. Now, the mechanisms that we see most commonly when we see autoimmune epilepsies is antibodies that are produced against either certain receptors or certain channels that are expressed on the neurons in the brain. And they can either cause dysfunction or stimulate the receptors inappropriately or cause destruction of the receptors. By doing this, they change how certain neurons either inhibit or stimulate their neighbors, so they can create a very excitatory state, which then can generate these seizures. There's also other types of autoimmune diseases that can cause both like local inflammation in the brain, but also it can be a remote effect coming from another part of the body, but leading to release of certain chemicals that can create an excitatory state in the brain.
Okay, so inflammation in a different part of the body can through a cascade of events end up leading to overexcitability. Okay, interesting.
Right, but that usually tends to be in people who may already have risk factors for developing seizures. One, again, not a true autoimmune disorder, but it looks to be a remote inflammatory cascade or conditions called febrile seizures. Now, these are type of seizure disorder that we see in young infants and young children, and they typically grow out of them. But for whatever reason, they have a higher risk when getting fevers or developing other infections to develop these type of seizures, which for the most part are benign when they grow out of, but again can be evident after infection in another part of the body.
Okay. So what are the key patient factors that would lead you to suspect possible autoimmune epilepsy, and what subset of patients with epilepsy should be tested for autoimmune epilepsy?
Okay. Well, there's been a lot of proposed, criteria out there. Most of it's clinical criteria because it's identifying based on the history where you should test these patients. Now, one of the thoughts are patients who present kind of out of the blue. Now everyone starts with seizures. They're fine one day and they're not fine the next day. But when they have a flurry of seizures at the beginning, that a lot of times will either come after an illness, such as infection or other GI illness or flu-like symptoms or upper respiratory infection, that come on really quick out of the blue and just are just surprising in general that how aggressive it seems to start at the beginning. Those other patients who also have epilepsy that you've kind of excluded most causes as well that you can attribute to either causing their epilepsy. So you want to exclude, previous injuries that happened either prenatally, so before they're born, or after they're born, any history of trauma, tumor, other metabolic or genetic conditions, or any other type of previous central nervous system disorders as well. Once you kind of identify that group, there's some other features that you can see that would kind of strengthen or increase your suspicion that there may be autoimmune epilepsy, and that one of them is being that they have a personal history already of autoimmune disease. Now that usually is when we say autoimmune disease, meaning that they produce some type of antibody that recognizes part of their body that and then becomes attacked because of that. The other thing is certain tests that we can do. We can test for some of these antibodies that are associated with these autoimmune epilepsies. The most classic prototypical one is the NMDA receptor encephalitis, where we can actually detect and measure the antibodies that occur in that individual, and if they're present above a certain amount, then we can use that as a tool to identify it. Also, one other test that we tend to do frequently in these children and adolescents and adults is to examine the spinal fluid. Now, the brain itself is bathed in spinal fluid, so these antibodies and other markers can be present in that fluid. We also tend to see in these patients an elevated white blood cell count in the spinal fluid. We can also see other measures of inflammatory markers, such as something what we call oligoclonal bands, which again are immunoglobulins, the IgG. We can also see what we call an elevated IgG index. Also, imaging sometimes can be helpful. MRI can show sometimes abnormalities that show evidence of inflammation. Now, this can be negative and still have autoimmune epilepsy, but if positive, it can also help us point us in the right direction. In some cases, of very difficult to control epilepsy or very unusual cases, they may have had actually a brain biopsy at some point because their seizures are just so poorly controlled and they've been in the hospital for so long. Or they've had epilepsy surgery because medications have not helped with their epilepsy. And then on the pathology, so under the microscope, we can see that there's this invasion of inflammatory cells to the areas where the seizures were happening. That can be a very good sign of evidence as well. Also, if they've had any type of immunotherapy, so they've had medications that do affect their immune system, and then they had a response with their seizure frequency or severity, that can be evidence as well. Even if there's no other direct evidence, if they're responding, say they had steroids for some reason or other type of immunotherapy and their seizures improved, then that can be enough evidence to either do further testing or to potentially treat if they've not been responsive to other therapies.
Okay. In general, if someone has tried multiple treatments and is not having any success, they clearly have intractable epilepsy or treatment-resistant epilepsy. And
right.
is that a case where even if they don't necessarily have any of these other indicators of risk for autoimmune epilepsy, is it worth someone talking to the neurologist about that as a possible cause? Because there are people who, for instance, also have difficult to treat epilepsy, but they have a suspected cause, like they have an identified lesion on the brain, or they had a stroke, or they had something else that they suspect was the cause. Is it still worth asking about autoimmune epilepsy, even if you don't meet all of those clinical factors that you talked about?
Yeah, definitely, especially in your medically refractory cases, and especially when it seems to be, temporal lobe epilepsy, especially bilateral, so on both sides, where the seizures seem to be coming from. Those are definitely cases to look at. Also, any case really that is not responding, it's definitely a diagnosis to entertain. A lot of the diagnostic tests that we do, a lot of them are straightforward blood work that are not prohibitively costly. Some of them are, but the screening tests that we can do in the office are relatively straightforward to do, and if you're not responding to traditional anti-epileptic therapy, it's definitely something to consider, because even if you're not following the prototypical pattern that we see for the majority, there's always going to be outliers who don't fit in that mold, right. Or cases that are a little bit more unusual that may be in fact be underlying autoimmune cause, and in those cases, the child or adolescent, they're not going to respond adequately to just medication alone for seizures. They likely will need some type of immunotherapy to get an appropriate response.
Okay. And with that in mind, how familiar are most neurologists with autoimmune epilepsy? Do patients need to seek out specialists who are willing to do such testing and who are able to provide appropriate treatment, or is this something that most neurologists, or at least most epileptologists, should be able to do?
Well, it depends, honestly. Right. It's becoming more and more recognized, but again, it's such a new field that a lot of physicians a lot of neurologists are either just familiar with it, just as a concept, but may not be comfortable enough to or know adequate testing to do, and also at that point how to treat, because again, most neurologists haven't had any background in treating autoimmune disorders. So when it comes to that, yes, do neurologists know about this? Most do. Are they familiar enough to diagnose and treat? No. In those cases, usually you have to seek out someone who has in the past or currently, treats these children. Again, it's a very new field. There's not fellowships in the United States or in North America, for that matter, that teach how to do this yet. This is something that will probably emerge in the near future as it becomes more and more, evident that there's a significant patient population where there's an involvement of the immune system in epilepsy.
Okay. And would you say that, in general, most level 4 comprehensive epilepsy centers would have at least one person on staff who would be competent enough or familiar enough with immune-related epilepsies to be able to handle it appropriately? Or do you sometimes have to look Okay, go ahead.
I would believe in most cases, yes. Okay. At least to do the diagnosis and the initial kind of initial treatment strategies that we use for autoimmune epilepsies. But there can be more difficult cases where it requires a different approach as far as the immune-mediated therapies, to the point where, again, it may be out of their comfort zone. So at that point, sometimes the neurologist will either work with immunologists or other specialists in autoimmune disorders, or we'll refer out to a center where there is someone that's recognized that has this experience using these more stronger medications for autoimmune disease.
Okay, great. And within your own system, I believe Dr. Shaw at DMC has a special interest in that. Is that correct?
He does. He does. So Dr. Shaw, he's one of our adult epileptologists. Correct. Yeah. So we're lucky in that fact that we have both pediatric and adult, which does help make it easier. So when I'm transitioning patients, it makes it a bit easier to transition to the adult side, because when you don't have that expertise both at the pediatric level or adult level, what usually happens is that the pediatric specialists will see these children now becoming adults kind of indefinitely, just because there's no one to fill that void as far as continuing and transitioning their treatment to the adult side.
Right. So there's probably not great estimates on this, but do you have any estimates in terms of the prevalence of autoimmune epilepsy? What percentage of people with epilepsy have autoimmune epilepsy?
Right. Now, there has been several studies in the last 4 or 5 years that have kind of tried to look at this, both in adults and pediatric and overall. One study suggested that there was anywhere between 10 to 15% of all epilepsies were related to autoimmune epilepsies.
Wow.
Now, that's overall, but when looking at specific populations, those who have refractory or intractable epilepsy, and those that have more of what we call focal epilepsy or complex partial seizures, that those estimates can go up to about 20% of those populations have underlying autoimmune cause. So when they've examined those populations and tested for these autoantibodies and other CNS inflammatory markers, the prevalence is up to 20% in some cases, in some series of patients.
Great. I may email you after this to find out what those studies are, so I can, because that's a really eye-opening stat, and I'd love to share that with our clients, because I don't think anyone would have guessed it was that high. So.
No, and you know what has happened in the past is that people haven't been looking for it, so you don't miss it. So the estimated prevalence is a lot lower in the past. But now when you specifically examine every patient that comes through your door for these disorders, whether or not you have specific things in the history, that's when you're discovering that yes, there's these other, it's relatively, in the grand scheme of things, a small portion of the pie, but it's still a significant portion that's not going to respond to your traditional treatments, that needs a different approach. So I think it's definitely it's exciting in the fact that you can now offer some families this other line of treatments that previously they thought that there was no other medical treatment available other than other types of adjunctive treatments, such as like a vagus nerve stimulator or potentially even surgery.
Right. So what are the various treatment options for autoimmune epilepsy?
There's anything that usually used to treat and suppress or bolster the immune system. More classically, the two are corticosteroids, so like prednisone or methylprednisolone or any of the oral or IV steroids that are used. Those are usually our mainstay treatments, especially when we first are diagnosing the patient. Long-term use of corticosteroids can be effective, but unfortunately the side effects long-term are usually significant. So usually for long-term treatment we avoid that just because of that, especially in children. Usually the other therapies that we use are IVIG, so that's intravenous immunoglobulins. So basically that's collection of donated immunoglobulins from people who have donated blood products in the past, and that's collected literally from thousands of people, purified, and then administered to them. Now, what's nice about that therapy is it doesn't suppress the immune system, and it doesn't cause an immunodeficiency. Actually, it kind of bolsters the immune system because it gives that person, hundreds and hundreds of people's experience with previous infections and antigens. But what it also does is it seems to quiet down the immune system. It turns it down a notch. That overactive, auto-reactive part of the immune system, it's able to kind of convert over to more of an anti-inflammatory state. So that's a very effective treatment.
And what exactly are
other things that
what exactly are immunoglobulins then?
So these are these antibodies that are made by the body. These are those little molecules that will attach to the foreign antigen. Mm-hmm. But in this case, we're not having them attached to anything, but their presence has multiple effects on the immune system. One, it kind of diffuses out the abnormal antibodies. Two, it turns certain types of cells off or turns them into a quiet, anti-inflammatory state rather than a pro-inflammatory state. So there's many different effects. And to be honest, there's probably more effects for IVIG that we just don't know why it works.
Okay. So other options?
So one of the other treatments that we do is actually a treatment called plasmapheresis. So this is kind of comparable to what you do for when you have someone on hemodialysis. You basically are filtering the blood. So you're taking out blood continuously, putting it through a filter, so filtering out the part that contains the antibodies, and then putting back in all the red blood cells and other cells that are present, and then putting in new plasma into the patient. And you do that in cycles where you basically are trying to filter off the, quote-unquote bad stuff, those autoantibodies, so that they can't cause injury to the person's self-tissues, so they don't have an autoimmune response.
Okay, and the plasma is also donated, I assume?
The plasma itself, the components, some of them are donated because, again, there are certain other things that we need in there, like for clotting our blood and other things like calcium and magnesium, which our body uses as well. So that's also put back in, and also albumin is another substance in that our body needs. So it requires a specialist to be able to do that. So it's not usually our first line unless it's medically necessary, but it's one of the treatments we do use that is quite effective. Okay. We also have a lot of other medications and drugs that we use. Those are medications that either target a portion of the immune system or are more cast a broader net and suppresses the immune system in a whole. One of those is a medication called rituximab. Now, that's a medication that actually can temporarily suppress the humoral or adaptive immune system, the one that has the memory cells that produces the antibodies. So this is actually a biological medication. It itself is an antibody that is infused into the patient. It binds to these cells that produce antibodies and causes the immune system actually to destroy part of itself. Now, this is a temporary effect that usually lasts anywhere from 6 months to a year. But again, it's not suppressing the entire immune system. It's only suppressing the part of the immune system that produces those antibodies. And again, it suppresses good antibodies, but also suppresses the bad antibodies, the one that are reacting to the patient's body.
And can you spell that medication? Sorry.
So rituximab, RITUXIMAB.
Okay, great.
All right. And that's usually infused. You get 2 doses roughly every 4 to 6 months for that. That's the one nice thing about that medication is that it's less often. Now, the cons to that medication is that you have to infuse it through an IV, and you have to be careful when you infuse it because it can cause an allergic reaction in some people. So you have to pre-medicate with things that will help reduce the infusion reaction, and also you have to closely monitor them while they're getting the infusion.
Okay. So it sounds like the majority of these treatments are things that really have to be handled under the care of an expert in those treatments.
Yeah, because any time that you are potentially suppressing the immune system or altering its function, you increase the risk for infection and other complications related to suppressing the immune system. So you have to also educate the families on what to look for potential complications that may not happen actually during like an infusion or otherwise, about looking for signs of other, types of infection that normally, if you had a fully intact immune system, that you may be more prone to developing. But we've had very good experience treating these children and have been able to minimize any of these potential risks as well. And these kids live a normal life. It's not like they're living in a bubble. You just have to be a little bit more vigilant regarding certain things.
Okay. And you mentioned some of the cost of some of the diagnostic tests being low for most of them, but higher for others. Are the tests and the treatments typically covered by insurance, or is that sometimes a battle?
Again, it can be specific to the insurance. Usually, most of the diagnostic testing can be done without needing an authorization ahead of time, but you have to be careful. So whoever is doing the testing, it's important that they're knowledgeable about which tests may actually need to be authorized before they're actually ordered. Because unfortunately, what will happen is if the test is done and there's not a prior authorization, then the families will get this, sometimes large bill, which is obviously something that the family's not going to like if they could be avoided. The same thing with medications. Most of these medications require prior authorization, especially the ones that are the medications that are infused. Now, we've had pretty good success. I would say probably 80-90% of the time we get these approved. The problem is that these disorders, in the grand scheme of things, are relatively rare and also relatively newly described. So getting the insurance company to recognize that not all these medications have been researched, that there's no controlled trials for these rare disorders, that there's not going to be an actual FDA indication specifically for this specific autoimmune epilepsy. We have a lot of evidence that these medications are safe and work in these conditions. It's just the insurance companies tend to make it more difficult because they argue that there's not the specific data, so they like to use the word experimental a lot when it comes to these treatments, and then usually I have to provide the research that's been done, the rationale, and the fact that there's really no other adequate treatment for these children, that without the appropriate treatment, their seizures are going to continue to be severe or even progress. They're going to have multiple hospital admissions. They're going to have, try to use more and more other medications, and some children are going to need to have more and more care, especially as they're transitioning to adult. So our goal with these medications are to, potentially reduce their seizures to the point where they're not having them, but also to kind of halt any of the other neurocognitive symptoms that can develop from having these seizures as well, so that they can live and be adults, independent people that can, contribute, have families, have a job, and not need to use their, insurance that much in the future.
Right.
So when you kind of rationalize it that way with the insurance companies, then they tend to change their tune a little bit, just because they recognize, okay, that this is a worthwhile treatment, and that despite the expense, in the long run, it's going to be in their favor. So.
Right.
It's a bit of a battle, but we have a good success rate with getting those approved.
Good. I expect it's different for each treatment in each individual, but in general, do immune-based therapies have to be continued indefinitely to maintain their therapeutic benefit, or can they ever be reduced or stopped?
Right. Yeah, it's definitely tailored to the individual and also to the very specific type of autoimmune diseases, because not all of them are equivalent in how they're managed. Now, that's one of the big questions, is because these disorders haven't been described for very long, is how long do you have to treat? Is this something that's going to be indefinite? Because most of the time you assume that their immune system is not going to change much. Once you've developed an autoimmune response, you anticipate that this is going to continue indefinitely. Now, there are certain ones that we do know that, okay, once we treat for a certain time period, some of them are, we treat for a year, and we know that we can then back off on the treatment and then see how things go after that if we have had a positive response. And others, it's literally trial and error, where after a period of time, which I've usually been using about 2 years on these treatments, then I start to kind of reduce the treatment, either the medication dose or the frequency that they get their infusion, and then see how their immune system, as you let it kind of go back to its natural state, is it going to have the same effect on causing the seizures? Okay. So that sometimes is a more of a trial, and that's done on an individual basis.
Okay. And again, this is obviously different for each treatment, but what are some of the common risks and side effects of these treatments?
Mm-hmm. Again, it depends on the specific treatment. Obviously, when you're using any of these medications and they are depressing or suppressing the immune system in any way, infection is definitely up there. Now, some of these other medications, long term, there may be potentially for the more stronger what we call chemotherapeutic drugs. Long term, there could be risk for secondary malignancies, so the developing cancers later on. Again, that's related to the one function of the immune system is to monitor our own cells when they change and become different, such as cancer cells. Our immune system a lot of times is able to squash that before it becomes a more systemic or a solid tumor. So those cells don't ever, progress to a more noticeable stage of cancer. So in some of the longer treatments or more significant chemotherapy, that can actually be a potential risk later on.
Okay, and what about like the corticosteroids or the anti-inflammatory medicines?
Right.
You mentioned earlier those tend not to be used long term because of the side effects. What specifically are those side effects?
So the corticosteroids, short term, there's a few side effects to consider, but they're not usually significant to the fact that we have to do any significant regular monitoring. But steroids long term, they can cause a lot of change in your electrolytes. They can cause changes in the way the body stores fat. So fat tends to be redeposited in different areas, in the face, on the upper back, along the torso. The arms tend to thin out. You can get thinning of the skin and get basically kind of stretch marks on the abdomen. It can cause the bones to thin prematurely, even in kids. So it can cause osteoporosis prematurely. It can also affect your blood sugar. Constantly being on a steroid can cause elevation of your blood glucose, your blood sugar. And if that's there long enough, there are some cases described where you have basically developing type 2 diabetes earlier because of that. So there's a lot of potential effects long term on multiple systems in the body for prolonged steroid use, which again is unfortunate because steroids work very well in affecting the immune system. Right. But again, these long-term benefits also can cause immune suppression, so they also have a risk for increased infection long term.
Okay. Can you talk briefly about some of the specific epilepsy syndromes that are known or either known to have immune an immune be immune-mediated, or that are maybe thought to be immune-mediated to some extent?
Right. So, there's most of the autoimmune disorders that are related to autoantibodies. So, other words that are described to these are like limbic encephalitis, where the more primitive parts of the brain are affected, such as the centers for memory or mood or movement.
can be affected. Now, these specific ones are related to the receptors such as the NMDA receptor, which is on most neurons in the brain, but are highly localized to areas where we develop new memories and where it's for movements. So when you develop antibodies to these, people develop seizures because of this. They develop significant memory and behavioral changes, and they can develop very unusual types of movement disorder. That's one that was actually just recently described in 2008. And before this, these patients were actually, more often than not, either passed away because of their epilepsy or were institutionalized because they looked like they had become psychotic, and eventually they become catatonic. So these individuals would have most often have been committed or had been subject to, electroconvulsive therapies. Actually, the original story for The Exorcist was thought to be based on one of these patients back in the 1950s. I believe that's the timeline, where they had these symptoms and actually had to be exorcised because of the severe behavior and unusual movements that they were displaying. There's other ones where we see against the voltage-gated potassium channel, which is another channel in the brain that is very common throughout the brain, but again expressed in certain parts of the brain where it's prone to causing seizures and other types of unusual types of movement during the seizure. Other ones that are associated with other types of potential tumors that can develop. A lot of these tumors, can be benign, but they're enough to stimulate the immune system to cause these type of autoimmune epilepsies. There's another group of disorders. One name for them is called Landau-Kleffner syndrome. The other name for them is continuous spike and wave during slow wave sleep, where you see children who develop seizures, and then after the seizures start, and you see this pattern on the EEG, the brainwave pattern, they start to have regression of milestones, either their motor abilities or their language abilities, where you see that their language starts to disappear. At least a portion of these patients are thought to have a immune-mediated process. Again, we're not fully understand a lot of these cases, but they tend to respond to either steroids or IVIG. There's other conditions as well, such as infantile spasms or West syndrome, that does respond to ACTH, which is our body's own version of a very strong corticosteroid. It's our normal stress hormone that we make from our brain that tells our body to how to respond and maintain our blood pressure and that. But you give these through an intramuscular injection to these infants who have these infantile spasms, and they respond to that. Now, is that because it has some immune modulating effect, or is it because there's some other receptor for it? It's not fully understood, but it's thought that there is a strong inflammatory component to those disorders. There's another condition called Rasmussen's encephalitis, where the child develops sudden onset seizures from one half of their brain, and with this development of seizures, they actually start to see half the brain start to atrophy, meaning that part of the brain looks like it starts to destroy itself. And most of the time, it only seems to be half the side. But these children tend to have some positive response to immunotherapy or plasmapheresis. Unfortunately, that condition, the only definitive treatment actually for those patients is to do a hemispherectomy, to actually remove the side of the brain that has the apparent disease. Now, there's more and more that have been being discovered. I mean, in the last 4 years, there's been 2 additional antibody-mediated CNS disorders. One of them was GABA-A receptor epilepsy. That one was recently described in, I think it was 2015, in the Lancet Journal for Neurology. Again, that's something that those patients would have either been treated
presumptively for autoimmune epilepsy, but they just didn't have the test for it, or they would have just been treated with conventional therapies and likely would not have responded the way we would have liked. So now that we're having more and more of these disorders identified, we can develop tests specifically for them to screen and tailor the treatments more and more into the specific condition.
Okay. And what about Lennox-Gastaut syndrome? I know that's a very difficult to treat one, and I've seen some connections with it to, it being immune-mediated, but is the jury still out on that as to whether?
Yeah, the jury is still out on that condition, just because there looks like there is a subpopulation of those children that seem to, at least if not partially respond, have good response to immunotherapy. Mm-hmm. Now, Lennox-Gastaut syndrome is kind of a wide spectrum disorder. So
right.
there's likely that there's multiple, both genetic or acquired disorders that cause that syndrome. So children who have had previous infantile spasms or other genetic conditions that lead to Lennox-Gastaut. But there is a small percentage of that population that there is at least either an inflammatory component or maybe possibly a true autoimmune. Again, it's just that hasn't been fully identified yet. It's hard to do some of the research in these patient populations because it's a lot of laborious work to identify potential either markers, biomarkers, or determine actually if there is an actual autoantibody in these disorders.
Okay. And what are some other autoimmune disorders that increase the risk of epilepsy? And it seems like that you mentioned earlier that people often have more than one autoimmune disorder. So is epilepsy in individuals who are diagnosed with autoimmune disorders more likely to be autoimmune in nature and treated as such?
It's definitely a risk factor. Again, it may lead you to test more frequently in that patient population if they already have an identified autoimmune disorder. There are some autoimmune disorders that do affect the brain indirectly, or directly. One of those is multiple sclerosis. So multiple sclerosis is a disease where the insulation, the myelin that's around the nerves in the brain, gets stripped away by the immune system. Now, by this alone doesn't cause seizures, but there is a portion of the population with MS, especially in the pediatric age range, that up to about 10% of them develop epilepsy. Now, that's not sure whether or not that's just because these plaques are occurring right next to certain tissues that then it's causing irritation, or if it's actually a direct epileptogenic effect. So it's actually causing those cells to then fire abnormally. Then there's other conditions such as lupus, where you can have either the blood vessels in the brain be affected and cause increased risk of having further damage or injury, or causing increased inflammation that can trigger seizures. Or you can have a direct effect right on certain types of cells in the brain, where you get what we call cerebritis, where you get inflammation of the brain itself. Now, again, there's other conditions too that we see where someone has a response to a certain infection and then has like almost a triggering a severe cascade of the immune system to trigger seizures. Now, these patients, a lot of times tend to not have any further seizures after this acute, like the sudden illness, but sometimes it's enough to set off an underlying seizure disorder because it causes secondary injury to the brain, such as a very prolonged seizure or other type of insult to the brain.
Right. Okay, so we've talked a lot about the role of the immune system in potentially causing epilepsy, but what do we know about, or let's shift to talking about the impact of epilepsy and seizures and the treatment of epilepsy on the immune system. So what do we know about the immune response after a single seizure, and particularly a prolonged seizure?
Okay. So now, in seizures that are not thought to be directly caused by the immune system, now the effect is also reciprocal, meaning that seizures do tend to trigger the inflammatory and immune response of the body, especially prolonged seizures. Now, these prolonged seizures can activate the cells that are in the brain called microglia. Now, those microglia, they're the resident immune cells that are in the brain. They're there from shortly after birth, and they're kind of the sentinel cells there. They constantly have their little tendrils out into the local environment, kind of monitoring for any disturbances. And once they detect a disturbance, such as prolonged firing of a neuron, they become activated. And when they become activated, they release, other substances such as cytokines, which are messenger substances that then recruit other immune cells to that area from the blood to inside the brain, where you can have other secondary injury because the immune system's now been activated and you're having this inflammation that's there. And that can make the previous seizures become reinforced. And that's a big area of research right now, is what effect does this have on causing further seizures or causing resistance of treatment of seizures after you're having these prolonged or frequent seizures. We also see that seizures tend to cause dysfunction of different parts of the brain, such as the blood-brain barrier, which is kind of this chemical barrier that protects the brain from the immune system. So when you have a prolonged seizure, this barrier kind of gets broken down temporarily, which allows, again, normally the brain is kind of a refuge from the immune system because you don't want the immune system too active in the brain because of these reasons. And now, because the barrier has been broken or temporarily impaired, you're now getting all these other things that normally aren't in there, coming there and causing problems. Now, if the seizures are prolonged enough or frequent enough, they can cause some of these changes can be permanent, and actually in some patients cause the process of developing epilepsy in these areas, or potentially kindling a new area of the brain that normally hadn't previously been affected, now becoming its own new focus of generating seizures.
Okay. And how do different anti-seizure medications affect immune function, and what, if any, precautions should people with epilepsy take as a result?
Okay. The antiepileptic drugs that have been used for epilepsy have been studied and how their effect is on the immune system. There are some drugs that seem to modulate the immune system, but overall the consensus is that there's not been any major effect of these medications on decreasing the immune system. Now, there are potentially some drugs that can cause what we call bone marrow suppression. So our bone marrow is cellular tissue that creates new blood cells, white blood cells, and platelets. And if you cause suppression of that, you can suppress the amount of white blood cells and therefore cause immune suppression. But these are things that are typically monitored by your neurologist when you're on these type of medications to make sure that there isn't this type of suppression. Usually what we do see, if there's any adverse effect by these antiepileptics on the immune system, is what we call like antiepileptic hypersensitivity syndrome, where you can potentially get a severe, almost like a allergic reaction. It sometimes can be life-threatening, usually a skin reaction that occurs to certain types of antiepileptics that can cause potentially organ injury in that. Again, this is a very rare phenomenon. Most of the time, families are warned about certain medications that can cause these more severe allergic reactions. There are medications such as like Dilantin, Tegretol, phenobarbital, Lamictal is a big one that we see that can, cause conditions like Stevens-Johnson syndrome, where you have this more of isolated to just the skin or mucous membranes. Trileptal is one that can have the potential to have these type of allergic reactions and immune-mediated reactions. Zonegran or zonisamide, and another one that we tend to not use as much because of the side effect is felbamate, which is used for specific epilepsy syndromes. Now, the only precautions we usually need to take is, we tend to monitor, your blood counts for certain medications. Not all medications need to be monitored. The other thing is that when you're first starting some of these medications, you just have to be aware that they can have this type of hypersensitivity or allergic reaction. Usually happens when you first start it, or when you're first increasing these medications, and that the families need to know that, if they see any signs of these, to seek immediate medical attention to make sure that these aren't in fact this type of reaction, and then if they are, that they should stop the medication and seek, if they need any additional medications to help with that reaction.
Okay. So, at least anecdotally, a lot of people say that illness and fever can sometimes be seizure triggers and just increase the likelihood of having a seizure. Is that somehow related to the immune response, or is it more a result of the general stress on the body that comes with being sick?
Well, from what we believe and know about it, technically both. It looks like that the inflammation that's created from infections that happen in the periphery, not the brain directly being infected or causing the inflammation in the brain, there is some hyperexcitability that's created in the central nervous system by some of these signaling molecules, these cytokines that are released. One of the mechanisms that we think, again, is that these microglia are becoming activated in the brain because of these cell signals that come from other immune cells outside of the brain and nervous system. And again, these microglia are responsible for recruiting other immune cells and other reactions in the brain. So that's one mechanism that's thought that, yes, an illness or a fever can trigger seizures in individuals. Now, again, we also think that stress on the body, because whenever you stress a system, there's only a certain limit that it can compensate until it kind of fails. And we think in people who have underlying epilepsy that those compensatory mechanisms that are there tend to fail sooner because of that as well. So I think both are true, and that's why we see in individuals who have epilepsy that during, fairly straightforward infections, like tonsillitis or viral infection or urinary tract infection, that it's enough that it lowers the threshold in these individuals that you see seizures happen more frequently or even come out after they've not been there for a while.
Right. So stress is another seizure trigger, and stress is known to impact immune function. So can you talk a little bit, just briefly, about how why it's important to manage stress, not only for better seizure control, but also for better immune function as well?
Well, yeah. So stress is a big thing. Again, it's not known how much actual overlying individual stress affects their immune system, and in regards to epilepsy, but there's multiple different models on how stress affects the immune system, but overall it's agreed that there is that significant like emotional or physical stress suppress the immune system. So it's important for any aged individuals, children or adults, that they know how to manage their stress, because in most cases these stressors in day-to-day life are unavoidable in most cases. So it's important to learn the techniques for that person on how to manage these.
Great. So before we open it up to questions, did you have any other closing thoughts that you'd like to share, or anything that that you think is important to touch on that we didn't touch on?
No. I mean, the big thing is that I'm glad we're having this discussion. Is increasing the knowledge, the general base, not only with physicians but with families, because usually it's families that bring these newer concepts to the physician's attention. A lot of times, it's we try to keep up to date on all the developments that happen in the field of medicine, even within our own specialties. But what happens is that the pace of new knowledge is accelerating, and the more and more information, especially within the field of neurology, sometimes outpaces what we can identify. And sometimes it just takes the right piece of information brought to the person's attention to potentially identify this, So in my practice, I'm routinely screening for these conditions, but it may not be the practice of another physician. So bringing these type of disorders, to the forefront and to people's, at least having it in the back of their mind that, oh, this could be there, even if they're not aware on how to test for it, that they're able to refer to someone or suggest to the family that they seek someone who has, that knowledge to do the testing. Because again, these disorders have potential treatment, and a lot of the times the treatment is pretty successful and profound, where other therapies and treatments have failed miserably, So, and as we discussed earlier, that percentage can be pretty high in the overall population of individuals, especially children with epilepsy. So we still have quite a ways to go in our knowledge and how to identify and to refine how we treat these kids. Again, because our treatments can be potentially harmful in certain circumstances, or they can potentially have side effects. But again, for the most part, the harm benefit, kind of things that we measure out, definitely weigh in the favor of treatment rather than not, because we do tend to see a significant improvement in, I would say, more often than not, in patients with epilepsy that are due to an underlying autoimmune cause.
Great. So, great. We're going to open it up for questions now. So, okay. Does anyone want to get started with a question? Okay, so,
yes, I have a question.
Yeah, go ahead.
I am new. This is my very first conference, and I have a son who is 24 years old, and he been diagnosed with epilepsy last year. And I noticed about the stress impact causing epilepsy. I noticed that he did get very upset about a work situation, and when he came home, he went into a seizure. That would be considered part of the immune function when you go into the overall stress, and is there a way to, recognize, or is there any suggestions on how to educate him on reducing his stress?
Right. So to go back to how stress affects seizures, it can either directly affect the excitability of the brain itself directly, or it can be through the immune system. So in this regard, because of how quickly the event and it was a specific event that led to it, it was more of kind of the stress on, causing his ability to compensate to kind of break down. So when we talk about stress long term affecting the immune system, that's different. So I don't know if this is necessarily the immune system involved in this case, but again, it's definitely a big impact that we can see stress on the frequency and the onset of a seizure as well. So it's basically, each individual is different when it comes to managing their stress, and it should be tailored specifically to the individual, their personal characteristics, so their overall age level, their level of maturity, and their ability to kind of self-monitor their state of stress, so that they're actually aware that they're under emotional distress, that they can actually say, oh, I'm feeling stressed right now, so that they can use a technique, either, self-relaxation technique, or doing, going, oh, I'm feeling really stressed, I should go do some exercise, or do something that reduces their level of stress. So it's going to be very different from a 6-year-old to a 20-year-old on how they're able to do that. But overall,
right.
Identifying what triggers stress in you and that being able to manage that, I mean, that's good health for anybody, but especially an individual who has underlying epilepsy.
So that stress and excitability go hand in hand?
Yeah,
Pretty
and
much.
also it's another thing that we see that tends to lower the threshold for seizures is sleep deprivation. So again, it decreases the system, so the brain's ability to compensate for their underlying epilepsy. So what happens is that these seizures, which are normally kind of, if you think of it as contained by a wall, this wall can be made taller or shorter by different things. So medications make the wall higher, stress, sleep deprivation, and illness make the wall lower, so the seizures can get out and spread. This is kind of the concept that's happening here. So being able to develop, strategies for management of your own stress can help prevent that decompensation that can happen.
Okay, thank you.
Great.
No problem.
Does anyone else have a question?
Okay, I have a question, and it's a question and a statement. Okay, so my son, he was diagnosed with epilepsy when he was 8, and he's now 24. In 2013, we had to put him into our epilepsy monitoring unit because none of the medications that he had been prescribed was working. And what was found, it was rather odd because on the last day of the stay is when when the seizure, had occurred, and then they had occurred back to back. And the doctor wanted to do surgery to remove a portion of the brain where the seizure activity was affected the most. And then he told me, I told him no, because my son, even though he's 24, he looks like he's 5 years old. And so I told him no, and I told him to go back to the drawing board, come up with something else, because I felt like that was too evasive or what have you, and he did. He went back to wherever it was that he was doing, and he came back and he said that, well, since the surgery is out, we're just going to have to try him with another medication because he is too small to undergo that type of surgery or what have you. But since then, my son's motor abilities, they have decayed tremendously. Like he's now contracted in each limb where he wasn't before. His abilities to move voluntary, he can't do any longer. Even so much as his swallowing ability. We have a GJ tube for him because he can't swallow like he used to. What is there to do? Because the medication that he's on now, which is Vimpat, it has been increased to 5 mL. He still has these seizures, and his seizures come on when the seasons change. So when winter goes into fall, he goes into 2 weeks of season. He'll have a seizure probably within the 2 weeks. He'll probably have them 8 days, not straight, but 8 different occurrences or what have you. So every time the season change, he starts to seize no matter what medication he's on, and the state that he's in is quite daunting.
Right.
So could you?
Sorry, go ahead.
No, I go ahead. I'm listening.
So, in these cases where you, like your son, who's had epilepsy for I'm guessing about close to 16 years, no matter what the underlying cause of the epilepsy is, after a while, you get permanent changes that happen in the brain. You get, you do get some injury, especially when you're having very frequent or very long seizures. You get parts of the brain that normally are developing, through our teenage years that are now, because of this very frequent activity, become they don't develop at the same rate or the same degree that would normally happen. Now, if you're seeing progression in a lot of the symptoms, yeah, these are cases where it may be worthwhile to screen for some of these autoimmune disorders, but because changes have happened, in the brain that are now permanent, independent of potentially any autoimmune disease, you can't reverse a lot of those changes, even if you treat the underlying disease. Now, that's why with these autoimmune disorders or autoimmune epilepsies, if you can identify them early enough, you avoid these changes that happen over time in cases of medically intractable epilepsy. Now, again, I think when you get to this point where you've tried multiple medications, and epilepsy surgery, I don't want you to get the wrong idea that I'm against epilepsy surgery. I'm definitely not. In the right patient, it's an amazing treatment. It's potentially curative, but it's just making sure that you're tailoring and you're evaluating for the specific individual that is going to be the most appropriate treatment. Now, in your son's case, I think it's still trying new things, but once you get past, your third or fourth medication, to be successful in controlling an epilepsy becomes, very, very hard to do. The percentage numbers are against you at that point.
Yeah, because this is the third medication, and I just figured we'll just try it, but as with others, it's the thing about I forget how they say it, but you increase it, then increase it more, and increase it more. I don't want to have to go through that, but with testing for the autoimmune diseases, would those types of diseases, would those come up like he's had multiple blood tests or lots of different tests? Would those diseases come up in any of these blood works, even though they're not looking specifically for an autoimmune, they're looking for something else? Would it pop up? Like, would it?
Likely no, because usually you're looking specifically for this. So it's a very targeted testing most of the time.
Okay.
So unless you actually test for some of these antibodies, or you're testing for the immune system being impaired, or having an abnormal response, you're not likely to see that. And again, the only thing that may be affected in an individual is their brain, their nervous system. There may not be other systems like the gut or the skin that may be affected, like in other autoimmune conditions. So it may not be outwardly obvious. So in a lot of cases, especially our medically refractory epilepsies that we may be considering for epilepsy surgery, or that were not felt to be appropriate for surgery, we're looking at them and doing this testing to see, because again, the percentages are pretty high for these disorders. And again, it may not always be, we may not always see these clues that are obvious based on the history. It may just be need to just go ahead and do the tests. And again, like I said, most of the tests that we do for screening are not excessively costly, and most of those ones are not needing authorization. Your larger panels of autoantibodies, ones that like Mayo Laboratories does or Athena Laboratories do, now those cost probably anywhere from $3,000 to $5,000, and those will require authorization through your insurance company, because again, if you don't get it and your insurance company says, well, we didn't agree to that, and the cost could be transferred to the families, which $3,000 to $5,000, that's not change, so.
No, it's not. I understand. So when I speak with his neurologist regarding this, or his PCP,
I would speak to his neurologist and get their idea about it. Again, they may think, because they're going to know him much better than I would, so they may say no, we have a pretty identified cause for his epilepsy. It's not likely to be a cause for the underlying cause is not likely to be autoimmune. They may say that it's unlikely, or they may say, okay, we could go ahead and test, or they may not know as much as they feel comfortable enough to do the testing, you know, again, because it's a fairly new group of disorders, relatively newly described in the last, you know, 10, 15 years.
Right, okay.
Okay, so
we
have time for maybe one or two more questions. Does anyone else have a question who hasn't asked one?
I'll try to make it quick. Thank you for the talk. I guess I wanted to know the specificity of the, like, biomarkers. So if you have someone who has refractory epilepsy that presents with no other predisposition to, like, autoimmune diseases or has no autoimmune diseases, and you do these antibody testing as well as maybe CSF or whatever, and is it specific for that, or do you just say, okay, now we think there's a likelihood, so we're going to be getting some type of treatment, like a corticosteroid, and then if there's no response, then you kind of exclude that? And then the second question related to that is, if someone has brain surgery for epilepsy, refractory epilepsy, the biopsy they take of the brain tissue, is that automatically just looking at the morphology? Can they tell if there's an inflammatory component, or is that not really evaluated?
Okay. So the first part of your question is that again, it depends on the specific autoimmune disease. Some of the antibody testing is more specific, meaning that you're not just picking up a false positive. Others, you have to make sure that you're measuring it in two ways. One example is the one where we see this, what we call anti-GAD antibodies, where it's important to measure it both once we detect it's present, we have to compare the levels that are in the blood and the levels that are in the spinal fluid, and actually create a ratio of those values to see, okay, is this antibody being produced at high levels, and if it's being produced at high levels, is it being mostly produced in the spinal fluid versus peripherally in the blood? And those are kind of things that we use to determine, okay, is this just a bystander effect, or is this a true central nervous system autoimmune disease? And that's what we use. For each one of those conditions, we kind of have to get the information in slightly different ways. But some of them are very specific, such as like the NMDA receptor antibodies. That's not really described incidentally in many other autoimmune conditions. It is to some certain degree. But then we look at the relative titers of those antibodies, so the relative level of those measured, and we see that if the titers are very high, it suggests again that it's likely a true central nervous system autoimmune disease.
Okay, thank you.
As for your second question, so when any type of specimen is sent for pathology after you're doing epilepsy surgery, it's definitely sent because you want to identify what you took out and making sure that, you know, if you're concerned that there's underlying cortical dysplasia or an abnormality of the formation of the cortex, the brain, and special stains are used to look at inflammatory cells that may be present. Again, one of the things, especially more and more often that's done, is to look for these inflammatory cells. Either affect
in an individual like that, there would be no place for biomarkers.
On the brain samples, no. It's hard to test for antibodies on the brain tissue itself.
Even in the blood. Like if it's ruled out through an actual biopsy, is there any role for a biomarker blood test?
Yes, there is, because some of the disorders don't have a strong inflammatory response. So those are the ones that have the antibodies that are more of a stimulatory antibody. So they actually will stimulate a receptor to fire and activate, rather than it causing the destruction of it. So there are some described stimulatory antibodies where just them binding to the receptor actually creates the effect that normally the neurotransmitter would do. So it's creating a false effect that there's not actually a signal being sent. It's the antibody creating this artificial signal.
Thank you very much.
And in those cases, you don't see the immune cells left there.
Right. Okay.
Okay, and Dan, you had a question?
Yeah, Dr. Williams, you just piqued my interest. We live in Michigan, and we're wondering about what you thought of my daughter's case in terms of the possibility maybe of coming to see you. she has congenital Lyme disease that she contracted from my wife in utero or from her breast milk or what have you. She started having febrile seizures when she was 1 and 2, which then developed into non-febrile seizures when she was 2 and 3. We saw a Lyme disease specialist that treated her for her Lyme disease, and we were seizure-free of any type for 4 years after that treatment. Just this past October, she had a cold and then started with a major cluster of grand mals, like 6 within a week. She was in the PICU at Hurley and everything. And we're wondering if there's some type of autoimmune Lyme component. Her Western blot doesn't show like a super active Lyme or co-infections right now, but we're just wondering if she's rashed out to like on 3 or 4 meds. The Lamictal, she got like an all-body rash, and she doesn't do well on meds at all, and stuff. And I'm just wondering what your thoughts were on the maybe likelihood of it, because we brought it up with some of her epileptologists that it might be autoimmune mediated possibly.
Right. No, that's definitely a possibility, but you bring up another thing that can happen during critical periods of development, especially in infancy. If you're exposed to any like significant inflammatory infectious cause, even if it's not directly affecting the brain itself, that can change certain pathways and connections that can create kind of more of an excitatory state in parts of the brain. So even though if there's no continued infection, you can still have, because of this critical period. We see this with other types of infections as well, not just Lyme, but definitely Lyme is becoming more and more in the spotlight, causing central nervous system issues. There's definitely a big debate about whether or not you actually can have chronic Lyme, or whether or not it's just an effect that persists after the Lyme is gone, that you're having on the brain, that affects both behavior and potentially, in some people, seizures. So again, the evidence is against Lyme being that chronic, but which kind of would be supported by her current Western blots being negative. So I'd be very surprised. But it does also seem to set you up more for autoimmune responses as well, because Lyme tends to be a very pro-inflammatory and stimulatory infection for developing autoimmune reactions. So it's definitely within the realm of possibility, especially if she's not responding to medications now, that she was seizure-free for a period of time. It's definitely a possibility that should be, again, in the grand scheme of things, these type of evaluations are not, these tests are not horribly expensive. I mean, like medications that we were talking about before, like Vimpat, covered by insurance, it's not too expensive. The copay may or may not be too high. But if you're paying for those medications out of pocket, that's, Vimpat, is a medication that probably costs anywhere from $400 to $800 a month, for standard dosing. Whereas the testing is probably going to cost you a month's supply of your drugs, and if you can figure out a cause, then it's worth it, and I think overall it is worth screening for these, especially your daughter's case.
Are there any, we just sent her blood away to Invitae to get the epilepsy genetic panel. Is there any thing that would be like a red flag that came back that would say that it is more autoimmune mediated or not?
Not with those panels. I mean, those panels are looking very specific for certain single gene disorders that are known to cause or be related to epilepsy. So those are looking more almost exclusively for a genetic cause. Now, we do know that there are genetic predisposition for autoimmune disease. You can see family, like it kind of passed down from multiple family members. Not always the same autoimmune disease, but you see a pattern that emerges. Someone has Hashimoto's, another thyroid disease, another person has lupus, another person has type 1 diabetes, these are all, another person has celiac disease. These are all autoimmune diseases, that are antibody mediated. So, and it tends to be kind of cluster in families as well, you know. So that also too is kind of you know, if there's that in the family, that could be the case. But you know, your daughter also has this history of the congenital Lyme, which by itself is a pretty rare occurrence. But
yeah, yep.
So
all right, thank you very much.
I think in that case it's worth doing.
Cool,
okay.
Thank you.
Well, I do want to wrap things up and thank you, Dr. Mitchell, for staying a little longer. And thanks, everyone, for participating. And, again, this will be recorded, so if you need to go back and listen to anything, it'll be on our website. So thanks, everyone, and everyone have a good evening.